So we're happy to be back to do our virtual conference this month, since last month it was postponed. We have all of our presenters here. We're going to be talking about Germany this month as our country of the month, where I just was visiting for the European Society of Emergency Medicine Conference. And our future participant, Isabel Luke, is going to present the status of emergency medicine in Germany. We actually just met in person at the conference, so now we're actually real life friends, not just online. And following that, we're going to have a great talk from actually an emergency department toxicologist and pharmacist, Renee Petzel-Gimbar from University of Illinois, Chicago, and she's going to talk to us about some clinically relevant toxicology information in emergency medicine. If we have enough people, we'll do our virtual simulation after that, but just after our first two talks, I'm going to do a quick announcement as our schedule for 2023 is finally done. And hopefully all of our participants have received their emails with their assignments and locations for next year. And so I'll give a little bit more information about that. So at no further ado, I'm going to hand it over to Isabel to talk about emergency medicine in Germany.
Thank you so much. Can you see my screen?
Yes.
Okay, so yeah, my name is Isabel Lück. I'm an attending in the emergency room in a hospital nearby Hamburg. We have 800 beds. We see a lot of patients. I'm also, I have the specialization for the intensive care. So I do a lot of emergency medicine. And I'm really happy to present the system in Germany. As you could already notice, I'm not a native speaker, so excuse my English, please. So yeah, the emergency medicine in Germany. So I wanted to talk where we are today, why we are there, and what went wrong, because there went a lot of things wrong in the development of the emergency medicine in Germany. So I would like to start with the ugly. And the ugly is that if you're saying in Germany, I'm an emergency medicine physician, this is what everybody thinks, the pre-hospital setting. So emergency medicine is taking place for a lot of people in Germany in the pre-hospital setting and not in the hospital. So in the pre-hospital setting, it's like the Wild Wild West. So it started without any need of a certificate. So everybody who wanted to be in the pre-hospital setting emergency job could do it. Who did not want it had to do it because the head of department said so. And it was more an eminence than an excellence-based medicine and structures. This changed in 2002 because they wanted at least some qualification. And this is not much what they wanted. So there's a super specialization. And again, here it's called the super specialization for emergency medicine. And it's not called for pre-hospital emergency medicine. This is why everybody thinks emergency medicine is taking place in the pre-hospital setting. You only need 2 years of clinical training. You only need 6 months in the ICU or in the anesthesia. So there are a lot of guys from anesthesia who are thinking they are emergency doctors. And you need an 80-hour course. And you need to do some days in the pre-hospital setting with another guy, but you can, like 50% of it, you can do the simulation course. And then you have some kind of oral exam. So this is what it takes in Germany to call yourself an emergency physician in the pre-hospital setting. So this is not much. In the hospital setting, there's no specialization. So we are having some problems with the consequences of it. And this is one of the problems that if you're saying I'm in emergency medicine, everybody thinks of a different thing than other countries, pre-hospital setting. But everybody is thinking that this is their own. So emergency medicine, it's mine. Everybody is thinking that emergency medicine is there. So pre-hospital setting, critical care, intensive care, cardiology, anesthesia, everybody's thinking they are doing emergency medicine. But, and this is the bad thing about it, they don't want to work there. They don't want to treat the patient. They don't want to work in the emergency medicine room, in the department. So the patient is not mine. Emergency medicine is mine, but the patient, no, it's not mine. So I like this picture of the patient and how we treat them in the emergency medicine departments in Germany. So this is a patient with abdominal pain. This is internal medicine, surgery, urology, gynecology, and everybody is saying, no, it's not mine, it's not mine, it's not mine, it's not mine. Nobody is taking really care of the patient or feeling responsible for it. And anesthesia, they don't do anything. They just look and say, okay, maybe no, we don't have to intubate them. That's all. So it's sometimes it's like that the people who really want to work in the emergency medicine and who are doing like their job in the department and who are trying to stay there, that they are having the feeling that they are like butlers for the others. They have to do all the stuff like talking to the patient, examine the patient, but if it's coming to some kind of decision making, they are saying again, it's mine, it's my decision. We only have the qualification of deciding what about the patient is, but we don't want to work there. So night shifts is okay. At night, no one wants to work there, but the responsibility and all the decided things, it's theirs. This leads to a really young team working there because everybody is rotating or has to rotate to the emergency department. So if you are there as an attending, as I am, you always have like the youngest of the youngest. They are doing their first night shift in the department of the emergency room, like with 3, 4, or maybe half a year. So it's like really little expectation and really they don't know a lot of things and they are really afraid of it, and so this is the youngest, so it's not the people who should treat critical care patient and critical ill patient and patient where you don't know what they have like on the in the emergency medicine department, as you know, and they don't have a team. So it's not that you have a team who are doing all the shifts together. You always have another person and then another person and then another person. And when the first person who's taken to your department gets it and knows how it works and what you want and why you can't do every time a CT and have this, who have learned some kind of this emergency medicine thinking, they are going back to the other departments because they're just rotating. So there's not really a like a team feeling which can develop because it's every time it's changing again and again and again. The good thing about our emergency medicine departments right now is that we are trying to change it and we're trying it hard, really hard. It's like since years we're trying to get the emergency medicine departments in our hands and that the others can give, can be like, we can ask them if we have questions, but that this is our place to be. So we have some kind of super specialization right now. Started in 2013, and they introduced it in Berlin, and since 2020, it's in every part of Germany. It is another specialization from 5 or 6 years, as it's in other countries. You need to be already specialized in something, and then you can do 2 years in the emergency department. You need 6 months of intensive care unit, and then you need again an 80-hour course. The good thing about it is that in 2025, every head of department from an emergency department needs at least this super specialization. So it can't be the cardiology, like the guys from the cardiology or an anesthesia. They do have to have the super specialization to lead a department. But, and this is a problem, the quality of learning and teaching content is pretty different in every part of Germany. It's not obligatory for the head of the department. So I know, as it's obligatory for the being head of the department, people are coming into the emergency departments who are forced to do the super specialization, but who are not having our own visions. And some people are saying that it's like a step backwards because it's like a calming strategy for us who really want to have the specialization. Because now people can say, yeah, we don't need the specialization because you already have something. We have a political development that they are trying to change the organizations of all the departments we have. So they have determined a strategy to reorganize everything, the whole EM system, but they have built up a catalog of requirements, but COVID blocked it some kind of. So they were trying to kick off hospitals without any good emergency department and without critical care, without an intensive care unit, without the CT out of the system because they are not economically useful. But COVID showed us that every hospital with chest beds can prevent the system of crashing. So COVID was some kind of blockade with it. And they are putting a lot of pressure right now on the hospitals to fulfill these requirements. In the system, again, COVID is but already under like a lot of financial strain, and a lot of, as the emergency departments are not in the focus of a lot of people because they are thinking emergency medicine is like in the pre-hospital setting. They are trying to get off, like to limit the resources of the ED, which are already reduced, because this is the easiest way to save money for the hospital, as we don't have a lot of lobby up. One good thing is our own society. So we have our own society, which is fighting for the specialization since years, and we have gained a lot more power than we used to have. We have a lot of members right now, and we have a voice that is heard by the politics. And this was a lot of fight and work, and but we achieved it. And of course, we have because of this society, we were in contact now with EMGLEX and with, again, like other countries trying to help us out, how we can get more power into this movement that we want this specialization. So the story is that we have some steps, we made some steps, and that we are trying to do more, and that I'm really, really happy to have this cooperation with EMGLEX, because I think that a lot of people will come back inspired of systems which they have never seen before, and that if they see how it can work, that we have a lot of more people in Germany with ideas how to change the system, that we are getting the specialization as well. And that if someone says in maybe 10 years I'm an emergency physician, that no one thinks that they are just on the street in the pre-hospital setting, but they are like an actual part in their own department with their own head of department in the hospital. So it's, again, a history to be continued. Okay.
Thank you very much. So for people listening, so just sort of to summarize, so emergency medicine is not actually yet recognized as a full-fledged specialty in Germany, right? It's a super specialty with very and inconsistent training for people who get that certificate. And as of now, it's not even required for the department chair to be trained or even work in emergency medicine. Okay. Yes. So for those of us in the United States, I mean, this is unfortunately not an uncommon story from many countries, especially in Europe, who have what you would expect, because they have well-developed healthcare systems and in high-income countries, and yet they don't have emergency medicine even as a specialty. And so that's really the point of why we're doing what we're doing. And so I'm hopeful that participating in the program will do exactly what you said and inspire some people and show them that there's a better way to do things, and start to give people ideas as to how to make that change. So thank you for that. I think this is really interesting, and I think that hearing about this is just not something that's available in really be anywhere. And so that's really why I wanted to do this, is this country of the month, to have this collection of stories about different places from people who work there themselves.
Mm.
All right. So let's switch gears and let's talk a little bit about something clinical. So we're going to change to actual internet, or talk about some psychology today.
If I can figure out how to, oh, there we go. Can you guys see my slides?
Yes, thank you.
Not in the presenter view?
Nope, it looks good.
Okay. All right. So hopefully I'm not going to get too much into the weeds when we're talking about this, but I get really excited about toxicology, and this in particular is something that I'm pretty excited about. So I will try and contain my enthusiasm. We're going to talk a little bit about just general concepts for acetaminophen toxicity, and then we're going to pivot to fomepizole, which is, for most people, something we think about for toxic alcohols, for things like methanol and ethylene glycol. But we're now thinking about and actually using it for patients who have massive acetaminophen toxicity. So acetaminophen is used all over the world. In the United States and other countries, it's available over the counter, so you don't necessarily need a prescription for it. I have some information just about what our exposures are here in the United States. We keep a database from all of the poison centers in the United States. So in the US, we have a poison center per state, essentially, except that some of our states do not have their own poison center. So you may have a poison center that covers 3 or 4 states. But we have a toll-free number that both lay people and then hospitals or healthcare facilities can call into to get advice when they've been exposed to something. And so we capture that data, and then it gets reported out yearly to give us an idea of what are the things that people are being exposed to. And so you can see we see about 300,000 exposures to analgesics. About half of those are to acetaminophen, either alone or in combination with something else like diphenhydramine or hydrocodone, things like that. What gets reported to us is less than 500 deaths related to acetaminophen, which is good. It's relatively low, although the way that this database captures information, there may be some underreporting there. We still see about 50 to 70,000 visits to emergency departments each year related to acetaminophen exposures. And if we look at our liver transplant data in the United States, about 50% of liver transplants are due to acetaminophen exposure, which is a huge number, or a huge percentage of liver transplants to be attributing to this one medication. The other thing that we commonly see is that it's mistaken for other medications. So things like aspirin or ibuprofen, any of the NSAIDs, that might also be in your medicine cabinet at home. Somebody thinks they're grabbing their aspirin, they're actually grabbing their acetaminophen, or vice versa. And so we can see that happen as well, where we think somebody got exposed to one thing and actually they got exposed to something else. We also have consistently seen these numbers of exposures, I would say, really over at least the course of my career, which is about 20 years. Even though we have an antidote or have had an antidote that is well known and people are usually very familiar with, we don't see decreases in these numbers of exposures. And so then just a little bit about kinetics, because I am a pharmacist, and this is something that I think about and look at when I have a patient coming in for toxicity. So if we talk about somebody who takes a normal dose of acetaminophen, it's rapidly absorbed and we'll see really a peak level within 30 to 60 minutes. This can be significantly delayed in some of our overdose patients, depending on whether they ingested the acetaminophen with something else or how large the ingestion was. After overdose, we usually see that absorption is complete with our usual expected time frame is about 4 hours. But like I said, that can definitely increase to 12 or 24 hours in some cases. The half-life is approximately 2 to 4 hours under normal circumstances. Again, that can be significantly increased. And it's metabolized in the liver, which is where all of our problems start. So I have listed here toxic doses for acute single ingestions. Really, we're probably not going to see significant toxicity until we see doses that are higher than this. But if you look in any run-of-the-mill textbook, this is what you'll see. And a good starting place for somebody who is not as familiar with acetaminophen toxicity to keep in mind in terms of a patient coming in and whether or not you need to see or you need to consider that they might have some toxicity. In chronic toxicity, we see some increased risk in patients who have pre-existing liver disease because of the effects it has on the liver. We also see acute febrile illness in children could potentially cause more significant toxicity. Patients with P450 enzyme induction, and I'll get into those P450 enzymes in just a few minutes, and then malnourished patients because they may not necessarily be able to compensate as well. And this picture I have here is from a in real life newspaper. The company that manufactures Tylenol, the brand Tylenol in the United States, actually does a lot of education of the lay public related to acetaminophen and not taking too much, which is great that we have them, trying to reach out to the lay people in the United States, although, again, we still see all of these exposures. I have this here, and it's actually a little bit outdated because, at least in the US, one of these formulations is no longer available. But I bring this up to show you all of the different formulations that my patients have access to, and I'll show you a couple more in a minute as well. I bring this up in particular because for us, I'm in Chicago. We are entering RSV and flu and potentially more COVID. And so we are seeing a lot more pediatric patients, and we have patients whose parents don't necessarily understand what an actual teaspoon is or how much they should give their child. And so you actually could see, accidental exposures in pediatric patients because they're not necessarily giving the right amount. We also see challenges when patients are taking different formulations. So this picture I have here is acetaminophen and ibuprofen. Dual action sounds so great until somebody takes too much, and then you are actually dealing with somebody that has ingested two substances and not just one. This is also another amazing product. I say that sarcastically for us in Tox because it is a modified release formulation. So a certain percentage of this formulation is released immediately, and then you have a smaller percentage, somewhere around 30%, 30%, that gets slowly released over 8 hours. And so that change in the kinetics can make it more challenging for us to treat these patients. And then another favorite of mine are these packets that contain 160 milligrams of acetaminophen, which for a child may help with them taking a dose if they have a fever, if they have the flu, but could also be very dangerous if a kid got their hands on them or an adult was trying to intentionally take too much acetaminophen. All right, so now we've got some pictures that make me very excited. I will say that when I started my career We knew a lot about acetaminophen toxicity, but really what we've learned over the last 20 years, I think is even more exciting in terms of what is going on mechanistically to cause that toxicity. So for the time being, I want you to ignore the red arrows on this and just focus on the main portion of these chemical structures. The structure at the top is acetaminophen, and then what you will see are the two main pathways of metabolism in the liver, and they are sulfation and glucuronidation. In pediatric patients, we tend to see more of the sulfation occurring than glucuronidation. Probably around the age of 12, 13, we see patients shift to having more glucuronidation. And then if you see the third arrow that's pointing down, that is a much smaller pathway of metabolism through the P450 enzyme system, in particular CYP2E1. And you can see it says on here that this is about 5%, but up to 50% in overdose. And so what actually happens is that sulfation pathway gets saturated. The glucuronidation pathway doesn't necessarily get saturated, it gets overwhelmed and can no longer handle all of the acetaminophen that the system is being flooded with. And then you get a shunting of all of that acetaminophen through the P450 enzyme pathway, through that CYP2E1 enzyme. You can see there are also other CYP enzymes listed there. Those enzymes account for a much smaller proportion of the metabolism, and really we think it's the 2E1 that is responsible for most of it on this pathway. And so then we'll see another structure that has NAPQI, NAPQI next to it. That's N-acetyl P-benzquinonamine, and that is what we refer to as the toxic metabolite of acetaminophen. So it actually binds to the central lobular region in the liver and causes damage there. It will also bind to other cellular proteins, forming these protein adducts that I'll talk about in a minute, that cause damage within the mitochondria. And that's where we see the toxicity develop. And so if we have somebody that takes a massive amount of acetaminophen, we can actually see pretty quickly a metabolic acidosis and an elevated lactate develop. And we think that's from what ends up going on in the mitochondria. So we're going to look a little bit further into that. All right. So again, I don't want to overwhelm you. I'm going to point out kind of the main important themes within this. So you can see on the left side of this slide, you have acetaminophen that gets converted or metabolized into NAPQI. We'll talk about NAC, which is the traditional antidote, in a minute. So if NAC is able to detoxify the NAPQI, then we don't have to worry about all of the mitochondrial issues that we see. When we go through all of our glutathione, NAPQI will bind to these protein acts, and what you can see towards the top of this slide is it then enters the mitochondria. It will allow for the production of oxidative free radicals. You can see superoxide here. And then that also allows for activation of the C-Jun terminal kinase, which we also refer to as the JUNK enzyme. That enzyme will then further cause damage in the mitochondria, allow for more permeability of the mitochondrial membrane, and actually then cause DNA fragmentation and apoptosis. And so it used to be that we would say that we thought NAPQI formed these free radicals, and then those free radicals cause damage. And a lot of work looking at in vitro models of what is actually happening has helped elucidate all of the things that are going on in the mitochondria. And so I think it's really important to understand this, even though it's more detailed and may make you cross your eyes, or your eyes crossed, because of where we see treatment for acetaminophen toxicity moving. That is with the potential use of fomepizole, which I'll talk about in just a couple minutes. This is the Rumac-Matthew nomogram. It was developed for single acute ingestions. I don't have time to go completely through it. I will say for toxicologists, we actually use this nomogram for a number of different situations. Even if somebody has taken multiple substances or took some acetaminophen and then took some more 4 or 6 hours later, there are a lot of ways you could potentially use this nomogram. It was developed, again, for these single acute ingestions. And so because we see really that the absorption and distribution takes some time after overdose, we start looking at the acetaminophen level at hours. The original line that Drs. Matthew and Rumac developed is this dotted line. And here in the US, the FDA actually required that line get lowered by 25%, and that is this black treatment line. So here in the US, a level of 150 micrograms per ml at 4 hours is at the treatment line, and we would initiate treatment for those patients. And so what does that treatment involve? So I'm going to bring up activated charcoal because as a pharmacist toxicologist, I am always a fan of charcoal if we can give it, because I think it works very effectively and will bind acetaminophen really well. So if you have somebody who comes in within a couple hours of their ingestion, you could go ahead and give them a dose of activated charcoal. I have the dosing as well as dosing for sorbitol. I'm not going to really touch on it any more than that. We also have targeted therapies, so I'm going to talk briefly about NAC, some more about fomepizole. I have hemodialysis on here for completeness sake, but again, I don't really have time to go into that in depth. All right, so let's get into N-acetylcysteine. So I have this picture again, and I want you to ignore the red arrows are seen there. So NAC is N-acetylcysteine, and it actually works by several mechanisms to decrease the amount of toxicity that we see from acetaminophen. And so you see the one red line has an A bucket. Essentially what NAC is doing there is sulfation, so allowing for more sulfation to happen to allow acetaminophen to not go down that P450 pathway, but instead be a non-toxic metabolite. Where you see the shorter red arrow for B, it's also a glutathione precursor. So it's going to help replenish glutathione stores. It also acts as a glutathione substitute. So it itself can bind with NAC, detoxify it. And then we also think that it is a free radical scavenger. So once we see toxicity develop, it may play a role in detoxifying some of those free radicals, superoxidative radicals that we're seeing. All right. So I have here the oral dosing. This is what was originally approved in the United States. It's a 72-hour course of therapy, although are shortening that course in patients who may not have ingested a massive amount of acetaminophen and whose liver function tests and coags return to normal within 48 hours or even within 36 hours, we're able to medically clear those patients and get them the psychiatric care that they may need. So that is definitely something that we've seen progress over, I would say, the past 20 or so years, where we aren't giving every single patient the full 72-hour course. The IV dosing was developed in Europe and was used there much more frequently than it was in the United States, although we now have an IV formulation that we utilize in the US as well. When the study was done looking at the IV dosing, they essentially had 100 patients. About half of them had multiple substances they ingested. And I have the dosing regimen here, which you'll note is the dosing regimen that we use to this day in the US and across the world. And so they found that as long as a patient got NAC within 10 hours of the ingestion, there were no deaths. And even patients who presented within 24 hours, there were really few deaths. Now, this was certainly a small number of patients. We also looked at this for the oral formulation in the United States as it was getting approved. And those patients, they were started on NAC within 8 to 10 hours of the ingestion. They found that there was less than 1% of deaths. It was like 0.54% of the patients died. So, for a long time, we've had this antidote that seems like it's very, very effective as long as we get it started as soon as the patient presents to the emergency department or to the hospital. So I have here, this is of the acetadote product that we use here in the US. Before we had this product, we would use the oral product and just filter it with a 0.22 micron filter. We still could do that if we had a shortage or an outage of this formulation. We do see with this formulation, especially in patients who have a history of asthma or COPD, that they can have these anaphylactoid reactions. And so by increasing the duration of that loading dose to 60 minutes, we've seen a decrease in that. Originally, it was meant to be given over 15 minutes. And so this 3-bag regimen that I have there has become the standard. Although now we've started looking at 1 bag that we adjust the rate or 2 bags. So those are things that we've started to see in the literature. Does it make a difference if we're doing this in 3 bags or 2 bags or 1 bag? All right, but what about dialysis, high-dose NAC, or fameprazole? Because these are things you may have heard about. I will comment just briefly on the high-dose NAC. That involves taking that 3rd bag that I just showed you and increasing the rate from kind of the standard rate to doubling or tripling that rate. If you actually look at the dosing that we use for the IV protocol, we actually are using a much lower dose of NAC than if we were to give the full 72-hour oral protocol. And so essentially what we're doing when we're giving that high dose infusion is giving them that extra NAC, which we think some of these patients may need depending on how much acetaminophen they ingested. They may have severely overwhelmed their body's ability to replete any of the glutathione to detoxify that NAC key. And so maybe these are patients that need much more NAC. And that's also where fameprazole comes in and what I'm going to spend a few more minutes talking about. All right. So for most people in medicine, fameprazole is known as a competitive inhibitor of alcohol dehydrogenase. And that is really important because that is how it will block methanol or ethylene glycol from being metabolized by that alcohol dehydrogenase and being converted to the toxic metabolites that cause damage in the eyes, in the kidneys. So that's traditionally what we have utilized it for. It also will inhibit 2E1, the CYP2E1 enzyme. And so that is also important for the metabolism of methanol or ethylene glycol, because the E in that 2E1 stands for ethanol. So 2E1 also metabolizes methanol, ethylene glycol, or isopropyl alcohol, or grain ethanol. But when we look back at how these gets metabolized, I talked to you for a couple of minutes about 2E1 in the metabolism of acetaminophen. So maybe the fomepizole could help in inhibiting that 2E1 enzyme in an acetaminophen overdose. We also have found through animal models and in vitro that it prevents the activation of this this JNK enzyme. And so if you remember when I talked about what happens in the mitochondria, really that JNK enzyme plays a critical role in initiating that process of metabolic derangements that happen within the mitochondria. So if we could somehow block the 2E1 with the fomepizole, that's going to potentially prevent the NAPK from being produced. And then additionally, I'll show this one again. I was trying to at least be consistent in the pictures I'm showing you. By inhibiting the JNK enzyme, you can prevent the amplification of this mitochondrial damage that's going on related to the oxidant stress and hepatocellular death. You're going to stop that JNK enzyme from entering other mitochondria, increasing that permeability and causing that DNA fragmentation and apoptosis. And so even if there is NAPK, this is a secondary mechanism that could stop that toxicity from further developing, which as a toxicologist and a pharmacist, I just think is completely fascinating and super exciting that it can work in these two different ways. This is just another picture showing how both the NAC and 4-MP, which is fomepizole, are acting within the mitochondria, interacting with glutathione or substrates for glutathione to try and decrease the damage that's happening within the liver and also potentially within other organs throughout the body. And so I wanted to present just very quickly some literature related to this. And so this case report from 2013 actually came out of our group in Chicago, Toxicon, and was reporting a gargantuan acetaminophen level in an acidemic patient that was treated solely with intravenous N-acetylcysteine. And so there is nothing related to fomepizole in the title of this article. And actually all they did in this article related to fomepizole was comment that a single dose of fomepizole was given initially because the patient had an anti-NGAP metabolic acidosis and they were found obtunded. And so there was concern that potentially they ingested a toxic alcohol. This was a patient that, like I said, was found down. Their acetaminophen level was over 1,000 when they were brought to the emergency department. And 2 hours later, it peaked around 1,200. They got started on the 3-bag N-acetylcysteine IV protocol. The next day, their LFTs were in the high 2,000s, low 3,000s, but essentially normalized by day 3, and on day 4, they were transferred to a psych facility. So who cares, right? We then had several toxicologists that read this case report and then challenged that maybe that single dose of fomepizole wasn't just a single dose of fomepizole to treat a potential toxic alcohol, but may have also helped this patient who presented with this massive acetaminophen ingestion related to its effects at the CYP2E1 receptor. And so since then, we've seen a number of different animal studies that have been done looking at animals that were given acetaminophen and massive amounts of acetaminophen and then treated with fomepizole. We've now seen multiple human case reports and case series where we again have seen patients that have these massive acetaminophen ingestions and then massive acetaminophen levels. And so we would potentially be concerned that, maybe we aren't giving them enough NAC to replete that glutathione. And then there has been one single controlled study that was done. They essentially gave volunteers 80 milligrams per kilo of acetaminophen. They gave them standard dose fomepizole, so they got 15 milligrams per kilo just before they got that Tylenol or acetaminophen, and then 10 milligrams per kilo 12 hours later. And so they measured acetaminophen conjugates and metabolites in both the plasma and the urine over the next 24 hours. They found similar peaks in both the groups for measuring a plasma acetaminophen level. But then they noted that in the group that got fomepizole, they saw a reduction in the percentage of oxidative metabolites from 4.48 to 0.51% of the ingested dose, which, again, for me personally, is pretty exciting to think about using fomepizole with NAC to treat these patients and hopefully improve their outcomes. So I think there is much more to come on this. I'm sure we are going to start seeing, and really at the talks meeting this fall, I think this was something that everybody was really excited about. So I think we're going to continue to see more and more on this. So when to consider. So for right now, I think, at least in our talks group, we think about this for these massive overdoses. Some poison centers will recommend only if the ingestion is greater than 500 to 600 milligrams per kilo. Others of us will be concerned about patients who are ingesting greater than 300 milligrams per kilo, which also would be approximately a tab if they were using the 325 milligram tabs versus the 500. So I think there's still some debate about that. A level at 4 hours of greater than 750 micrograms per ml. Although, again, there's discussion. I think some toxicologists would consider this at even lower levels than that 750, 300 to 400 micrograms per ml. We have the luxury in the United States of having poison centers, and so often we are involved in caring for patients through the poison center and make that recommendation from our medical toxicology service. And then also thinking about, again, using this in combination with an acetylcysteine and then also hemodialysis. So I didn't get to really touch on hemodialysis, but hemodialysis would help with some of the metabolic derangements, the acidosis that we see develop. It would pull off some of that acetaminophen as well, and work synergistically with both NAC and fomepizole. So I have the standard dosing listed here. I will say that I think a lot of us as toxicologists still don't necessarily have a good grasp on what the time frame is for giving the fomepizole, how many doses we need to give. a lot of the case series and case reports, a single dose gets given, and then no more is given because the patient starts to improve, their acidosis starts to improve. I think that's something that we haven't yet completely figured out, but giving a one-time dose in these massive ingestions, I think is a good thought to have, and maybe something that is brought to your attention if you have one of these patients, or you might think about if you have one of these patients. And so I don't want to take up too much of everyone's time. You know, I think this is just another example of the evolving nature of medicine, things that we thought were well understood, you know, 20 years ago. Now we've seen all of these elucidations of the mechanism and specifics related to the mechanism of toxicity. And so that's going to allow us to use multiple antidotes and things we wouldn't have necessarily thought of in the past for acetaminophen toxicity. I will say here in the US, fomepizole is not an inexpensive antidote. And so that potentially could weigh into your decision making, as much as I don't like to bring costs into things, because this is something still that is very novel, and we know that NAC works very well for a lot of these patients. Choosing not to use fomepizole, I think is something that sometimes that's the decision that gets made, but also in a time of shortages and outages, if I didn't have any NAC, then could I reach for fomepizole as an alternative? I think is something that I've also started to think about. Obviously not ideal, but at least we have something as opposed to nothing. And that is all I have for everybody.
Thank you, Renee. That was really interesting. I didn't even know about this at all. So I learned something new today too. I have a couple questions, and then I will open it up to anybody else who has a question. So number one, is this something that's going to be on the Toxicon protocol for the Illinois Poison Control Center?
Great question. It is not currently part of the protocol. If you were to call and speak to a specialist in poison information, if it was one of these massive ingestions and Toxicon got involved, it's definitely something we would talk about with you.
Okay. And my other question was, I know it's kind of expensive now, but similarly to like IV acetaminophen, ironically, do you foresee, and this is like a total opinion, do you foresee if we start really using this as a more standard treatment that the cost would come down? Because I think that's kind of what happened with the IV Tylenol. It started out really expensive and now it's not, and we use it all the time. Do you think that that's part of why it's expensive because we don't use it a lot, or is it just hard to, I mean, I'm just asking out of curiosity.
I don't know. It certainly would behoove the company that produces it to make it less expensive.
Yeah. Once or twice, like ever in my career, so you know, we don't see it a lot, but
yeah.
Okay, cool. So this would be something really to get from the toxicologist as a recommendation, or from a poison control center, not something that's really standard right now.
Yes, correct. So, I mean, if you had a massive ingestion and the wherewithal to remember this, and you had a hospital pharmacist that was willing to let you try it, sure. But
an interesting idea. Has it been studied at all for the like less acute, like subacute ingestions that show up a couple days later? Not at all.
Not that I'm aware of. Although that doesn't mean that somebody isn't going to try and use it and then we'll have a case for it. So, I mean, the great thing about tox is that as much as it may not be a good thing in Germany for emergency medicine, we are kind of the cowboys in the wild, wild west, because we can't in people and see what happens.
Right. I was wondering with that study, how did they get IRB approval for that?
I mean, I think it would have been cool to be part of that study.
That's really interesting.
Yeah.
Right. thank you very much. This is really
Yeah.
positive, and I'm really happy you were able to do this for us today. And we will talk more later.
Yes.
But we'll do it off of the conference. So
Okay, awesome.
So that's kind of it for our talks today. It looks like we don't have a ton of people here to do our simulation this month, so I think we will postpone that until next time. I think number one, I know that the number of people that were going to be joining from Germany to do the sim case got COVID, so they are not available. But we'll do it. We'll do like a combined one next month for our next virtual conference. So very quickly at the end, as I promised at the beginning, I'm just going to talk very quickly about program developments for those of you watching later on YouTube. So the schedule for 2023 is finished. We are going to have a total of 6 visiting residents per month. 3 will be coming to Chicago, 3 will be coming to Gainesville, Florida, to the University of Florida for their rotations. Everyone should have received an email with their assignments. And so for those of you listening that are curious, we're going to have lots more information coming in the next week or so about housing and more logistics, and your schedule will be made when you get there. That's all based on my schedule and other people's schedules. So you will be given a schedule for what types of shifts and where you're going to be going on the days of your rotation. Then we'll have much more information as well about the different conferences and meetings for those of you who are going to be here during the months that we have those. I'm hoping we can get everyone to come with to the ASAP conference in Philadelphia this year, well, next year in October. I think I mentioned this before, but if I didn't, I was just appointed the new chair of the ASAP Ambassador Program. So I will most definitely be in Philadelphia, and we'll be doing lots more international work throughout the year. So I'm hoping to find ways to get everyone more involved with that. And if you have an interest in ASAP or learning more about the ambassador program or the international section, please obviously talk to me as well about that. So I'm really excited about this next program. As we mentioned in the other presentation, COVID shut a lot of stuff down, including this program. But we are coming back better than ever. We are 3 times the size that we were before. And instead of having one country, which was Italy at the beginning, we had applicants from 17 different countries on 4 different continents. And so we have representation from a wide variety of places and systems. And so I'm really looking forward throughout the year to learning more about each of those countries when we feature them as the country of the month, and to share the challenges and things that we're all facing. And like I said at the beginning, find ways to work together to approach them and make them better. So we're not going to do sim this week just because, again, we don't have enough people. We will do it next month, and we can look forward to that. We'll make that a little bit larger section of the program next month. So if anyone has any questions, please send me a message. You can do it through the website, or you all have my email. And I look forward to seeing you next month. Our next virtual conference is going to be December 1st. So the first Thursday of the month is December 1st. Same time, same link, and that's about it. So thank you all for attending. Thank you for listening on the YouTube channel, and we will see you next time.